Hello everyone, this presentation is to introduce how to design performance measures. Performance measurement is a use of quantitative tools, for example, rates, ratios, index, percentages to provide an indication of an organization's or program's performance in relation to a specified process or outcome. Performance measures can be calculated as following. Proportion is a piece of the whole. In a proportion, the numerator is expressed as a subset of the denominator. The following is an example of a proportion performance measures. Proportion of ischemic stroke patients discharged on antithrombotic medications. And the next is the ratio. A ratio is a relationship exists between the numerator and the denominator, but the numerator is not a subset of the denominator. The following is an example of a ratio measurement. Number of medication errors per 100 shifts. The third is a continuous variable. Is an aggregate data measure in which the value of each measurement can fall anywhere along a continuous scale. The following is an example of a continuous variable measurement. Average number of days to fill 5 open staff positions. 6 plus 14 plus 32 and plus 21 plus 12, you can get 85 days, and you divide it by cases, you can get 15 days per case average. So this is a continuous variable. Types of performance measures, you can classify clinical measures. Clinical measures are designed to evaluate the process or outcomes to care associated with delivery of clinical services for the patient population in question. They allow for intra and inter-organizational comparisons that can be used to continuously improve patient health outcomes. They may focus on the appropriate of clinical decision-making and the implementation of those decisions. These measures must be condition-specific or procedure-specific, or address important functions of patient care, for example, medication use, infection prevention and control, patient assessment, patient safety. Administrative financial measures address the organizational structure for coordinating and integrating services, functions, or activities across operational components, including financial management, for example, financial stability, staff credentialing. Perception of care service measures. Perception of care service measures are satisfaction measures that focus on the delivery of care or service from the patients and other customers' perspectives. Measure may address one or more aspects of care or service. For example, satisfaction with providers and other staff, or satisfaction with the care environment. These measures are specific for the patient population certified. Quality improvement is a sequential dynamic process involving ongoing cycles that measure clinical practice compared with evidence-based benchmarks of the best practice and then devise and try out a strategy to improve implementation of the best practice. The clinical hospital operations measures tool is a sample form on which hospitals can record the method that will be used to evaluate the uh, effectiveness of ongoing compliance with the measures related to the priority improvements identified by leadership. This tool may also be used by the department service leaders when selecting measures specific to their department or service. The tool will provide a consistent process for documenting each element of the selected measures. The following information should be identified before collecting and measuring data to ensure that the process is clear and transparent. Category of the measure, for example, strategy, priority improvement, or individual department service, and owner, staff name, source, and the definition of the measure for the monitoring requirements. Rationale for selecting the measure, type of the measure, structure, process, outcome, or process and outcome, reporting time period and the frequency of assessment of data, methodology for data collection are retrospective or concurrent, target sample size and the threshold, target to demonstrate the expected performance outcome. Data aggregation and analysis plan to transform the data collected into useful information to reach conclusions and make necessary decisions in response to the results. Communication plan for reporting results to staff. Name or file name for the audit tool use. For your performance measure, what is the easiest way to collect data? If you concern past a week or few weeks ago data, you can choose retrospective method. As patients come along from the start date, you can choose concurrent method at the same time as caregiver. Sometime in the future, after you find a way to find the patients, for some clinical audit subjects where it's hard to find the patient from files, you can choose the prospective method. Target sample and the sample size, deciding on a population or sample. Specify the exact cases to be included and excluded from the measure, and find out or estimate how many there are in a given time period. And can you find all the cases? If yes, do you need to include all? If yes, is there time to include all? If yes, use a population. If no, use a sample. Okay, so this is a flow chart, target sample and the sample size. Left side is a star and the square population. Right side is star and the square samples. However, you can find right upper side is even, representative, and the right down side is not even, non-representative. Specify the exact cases to be included and excluded from the measure. Find out to estimate how many there are in a given time period. Can you find all the cases? If yes, do you need to include all? If no, use a non-representative sample. Do you need to include all? If yes, is there time to include all? If no, do you want to represent the population? If yes, use a representative sample. If no, use a non-representative sample. Is there time to include all? If yes, use a population. If no, do you want to represent the population? If yes, use a representative sample. If no, use a non-representative sample. Representative sampling method. We can classify simple random, stratified random, systematic random, and cluster. A simple random sample is a subset of a statistical population in which each member of the subset has an equal probability of being chosen. A simple random sample is meant to be an unbiased representation of a group. Stratified random sampling is a method of sampling that involves the division of a population into smaller subgroups known as strata. In stratified random sampling or stratification, the strata are formed based on members' shared attributes or characteristics, such as income or educational attainment. Systematic random sampling is a random sampling method that requires selecting samples based on a system of interval in numbers of population. Cluster sampling is a sampling plan used when mutually homogeneous yet internal heterogeneous grouping are evident in statistical population. It is often used in marketing research. In this sampling plan, the total population is divided into these groups known as clusters. And a simple random sample of the groups is selected. The elements in each cluster are then sampled. If all elements in each sampled cluster are sampled, then this is referred to as a one-stage cluster sampling plan. If a simple random subsample of elements is selected within each of these groups, this is referred to as a two-stage cluster sampling plan. Non-representative sampling methods, purposive, convenience, quota, and consecutive. Purposive, as PowerPoint show, I want you, you, and you. Convenience is I can get you, you, and you. Quota is, for example, congratulations, you and you and you are among the first 10. Consecutive, yeah, I am starting with you, then you follow, then you follow. Okay, this is an example non-normative sampling. Principles for deciding on sample size. How many cases will a clinician or a team want to be willing to act? Will a clinician or a team want to generalize from the findings on a sample to a population? If a clinician or a team wants to generalize, the sample has to be definitive, large enough for a clinician or a team to be confident of the data. Questions for decision on sample size. How big? Large population, large sample. How often? More or less frequently, small sample. 50% large sample. How sure? Level of confidence, 95% or 99%. How exact? A range of accuracy, 2.5% or 5%. How to determine a target and or threshold? You can refer following factors to determine target threshold, like the history data, peer review, regional or national, accreditation standard or official requirement, protocol guideline literature or reference. It is expected that initial measurement will not reach the target. However, when strategies for improvement are implemented, department service leaders should expect to improve toward the target. When a target has been met and sustained for at least 4 measurement periods, a new measure is selected. This trend chart shows a positive effect of care on patients for measurement period to performance improvement. A quality improvement program is only as valid as the data that are collected. If data are flawed, quality improvement efforts will be ineffective. The reliability and the validity of measures are thus at the core of all improvements. To ensure that good, useful data have been collected, an internal and external data validation process needs to be in place. Data validation is most important when a new measure is implemented, in particular those clinical measures that are intended to help a hospital evaluate and improve an important clinical process or outcome. Data will be made public on the hospital website or in other ways. A change has been made to the existing measure, such as the data collection tools have changed, or the data abstraction process or abstractor has changed. The data resulting from an existing measure have changed in an unexplainable way. The data source has changed, such as when part of patient medical record has been turned into electronic format, and thus the data source is now both electronic and paper. The subject of the data collection has changed, such as changes in average age of patients, comorbidities, research protocol alertions, new practice guidelines implemented, or new technologies and treatment methodologies introduced. Data validation is an important tool for understanding the quality of the data and for establishing the level of confidence decision makers can have in the data. Data validation becomes one of the steps in the process of setting priorities of measurement, selecting what is to be measured, extracting and or collecting the data, analyzing the data, and using findings for improvement. Components of validation identify a random selection of data source for the abstraction from same sources. Perform the abstraction of data second person. Compare original data with the abstracted data. calculate accuracy, determine discrepancies of data abstraction and re-abstraction, implement corrective actions, collect a new sample after corrective actions implement. Identify random select of data source, determine a statistically valid sample of records, cases, or other data. Samples are randomly selected and should be across a range of variables. For example, deaths, patient types, instances, and staff involved. Initial sample size table. Verify number of sources reviewed for initial sample. Determine statistically valid sample of records, cases, or other data. Total monthly initial patient population size greater than 640. Required monthly sample size is 128. Total monthly initial patient population size 320 to 639. Required monthly sample size recommended is 20% of total population size. Total monthly initial patient population size 64 to 319. Required monthly sample size 64. Total monthly initial patient population size smaller than 64. Required monthly sample size no sampling. 100% population required. Samples are randomly selected and should be across a range of variables, for example, as patient types, instances, staff involved. This is an example for MI major implementation. 100 cases in a quarter meet the inclusion criteria appearing on arrival. Sample size is 100%. 50 cases have appearing on arrival within 24 hours documented, and 35 cases have contraindications excluded. 15 cases have either documented, calculated percent of compliance. We got 50 cases out of 65 show compliance with measure. 50 cases are not compliant, so we can get 50 over 65. We got 77% compliance with measure. Example measure validation: select and train a second person to perform abstraction in the same way as original abstractor. Verify pool of cases, denominator verification. Re-abstract data from identified random selected sample. Re-abstraction utilized the same data definitions. Second person does not review previously abstracted data prior to re-abstraction. Verify number of sources reviewed, determine statistically valid sample of records, cases, or other data for validation. Total number of data sources 1 to 16, recommended sample size or data sources. Total number of data sources 17 to 160, recommended sample size minimum 16. Total number of data sources are 161 to 480. Recommended sample size 10%. Total number of data sources greater than 480. Recommended sample size 48. Samples selected should be a range of variables such as deaths, patients type, incidences, staff involved, same as major. Random sampling, we have 100 patient files, needed a minimum of 16 files for validation. 100 divided by 16, every maybe 6, you can select number 3, 9, 15, 21, 27, 33, 39, 45, and the following as 16 samples. Example for MI major validation as per on arrival. Validation includes a sample size of a minimum 16 cases. Minimum 16 cases for data source of 16 to 160. Random selection 100 over 16, we got 6.25 every 6 from original 100. The abstraction of 16 random selected cases reveals that cases have appearing on arrival within 24 hours documented. 2 cases have contraindication excluded. 6 cases have neither documented. Calculate compliance. 8 cases out of 14 show compliance with measure. 6 cases are not compliant. So 8 over 15, we got 57% compliance with measure. Compliance from original data source is 77%, while sample reveal a compliance of 57%. Compliance from sample size should be within 90% of original or compliance percent. For example, 60%. 90% multiply 77%, we got 69% level not valid. Original and the second abstractor review measure and the data source to identify possible causes of discrepancy and take action or repeat re-abstraction until meets 90% compliance of original. Possible cause of data discrepancy. Abstraction guidelines not clear or misinterpreted. Definition of data element not clear. Training of abstractor may have been different. Parameters of collection may not have been identified. Data terms may not have the same meaning. Missing elements omission does not apply. Incorrect data entered. Conflicting data in record. Different data source used. All right, we finished our class about how to design performance measures which you implement in your hospital. Thank you for listening.